That's cardiac. Any more questions on cardiac? I've been giving you all the answers the whole semester. Like, you've literally done the CPSA probably 5 times, or something very, very similar to them. Yeah, honest assessment's no tricks here. I'm not gonna make up some like pericarditis just to mess with you guys. It's gonna be stuff that you've seen and you've done lots of times and we emphasize in the program. There was actually my first year teaching, I was like, I don't know what to test them on, so I had a couple students, guys, what do you think is gonna be on the test? And then I just basically did whatever they wrote down. It was great. I did that as a big class too, so they were like, oh my god, yeah, we're so smart, we figured out what Matt wants. Okay, rapid trauma assessment. So I just made this flow chart. It's not up on SAM yet, but it will be up before I leave. I think this is pretty accurate. Rose hasn't had a chance to check my work, but it looks pretty good. So we show up, we're gonna do our scene assessments. We're looking for hazards, number of patients, mechanism of injury, general impression, what resources do we need. When you're doing your scene assessment for your trauma patient, we're also considering C-spine. So thinking about that mechanism, and they're all listed in the Canadian C-spine rule. So we're looking at the older patients, do they have any paralysis anywhere, or is it a high mechanism injury? So somebody falls off the top of a building, we're automatically getting C-spine. Somebody stubs their toe, they probably don't need their C-spine help. If you're ever unsure, so when you do that walk up, that scene assessment, and you're like, I don't know what the mechanism is here, or I don't know if it's bad enough or not, just hold their head. It never hurts to just hold their head and like manually hold it until you get to your head to toe and you can clear C-spine. Does that make sense? And then you don't have to worry about missing a C-spine injury. You just partner, hold their head. I'm gonna do my A, B, C, D, E, and then once I get to the neck and my head to toe, we'll figure out if we need a collar on or not.
So that was a question I asked you last week. Like a little girl was hit by a car, just really shallow. Would you initiate ventilation, or would you check her C-spine first? And the answer was ventilation. So not the C-spine. So I didn't know.
Understood, yeah. Gotcha. I
I
think what they were trying to test in that one is you're at your primary survey already. So yeah, I know the question you're talking about. I bet you that's where somebody else asked me that question about breathing and C-spine. So give me 2 seconds, we're gonna get through that one. So now that we've done our scene assessment, we figured out what's going on, maybe partners holding C-spine, we get to our primary assessment. So A, B, C, airway, breathing, circulation, deadly bleeds, and expose the patient, also consider environmental stuff. Everyone should have that down pat by now, but I'm still getting the blood out of my clothes. Cool. If we have somebody with a problem, we delegate it. So if it's me and Nate, me and Nathan work together, and patient has blood in their airway, all right, you're up to start suctioning, so I can go and check on the next thing. If we had to choose between C-spine and any of the ABCs, get rid of C-spine. Just let go of C-spine if I need the people. So me and Lily are working together, and we got somebody with 2 deadly bleeds, and Lily's holding C-spine. Yeah, let that go. Come here. No good to hold C-spine if he doesn't live. So let's fix those. Does that make sense?
So, sorry. So if you have airway secretions or something, your partner was holding C-spine, and you needed the airway cleared, would you drop C-spine and have the partner do that, or would you just suction yourself?
Great. If I can suction it myself quickly and it doesn't slow down time, then sure. I might grab the suction and just throw it next to Lily and say, hey, you're holding C-spine, can you suction while you're there? And then Lily might let go, suction quick, and then hold it again. Or she could use her knees to hold C-spine, something silly like that. Does that make sense? Because we've done sims with like multiple people, this doesn't come up a whole lot where you have to like triage which A, B, C, D, E, like which one am I gonna save? When you have 2 people, you might have to. So you might have to decide, no, C-spine's not getting held because I'm working on my ABCs. And that's fine, that's okay. We need the guy alive. Cool, cool? Awesome. While you're on scene, we're gonna do that physical assessment, that rapid head to toe. We are fixing things as you find them. So anything that's life-threatening, we're gonna fix it right away. Things like broken wrists, like broken toes, like broken collarbones, not life-threatening, don't care. Minor scratches that aren't crazy bleeding, don't care. We'll deal with that when we get to it. So it's the life-threatening bleeds, the needle decompression, or the tension pneumos, organs hanging out, pelvic fractures, femur fractures, if you can put the splint on quickly. With the new femur, the traction splints, apparently they're going on, well, I know they're going on pretty quick. Apparently they're working fine. So yeah, if you can get that on really quick, sure. If not, just do it when you get in the back of the truck. Does that make sense? Okay.
Me?
Yeah, yeah.
Yeah,
You had a little bit of a glazed look there for a second. I was like,
I
oh,
was
this is.
glazed, but
It's okay.
I'm hearing.
I got you.
hearing
The other thing when you're doing your primary and your physical assessments is we're delegating as much as we can. So again, the goal for trauma is the surgeon and the patient should be in the same room. We're trying to get those two people in the same room, preferably in the operating suite. So anything that speeds that up, we're gonna do. So we're gonna delegate as much as we can so we can finish our rapid assessment. We're only gonna fix the life-threatening things because the life-threatening things are what's gonna keep him alive. If we fix those, he'll be alive so we can get him to the hospital. The minor stuff, we don't wanna let that slow us down. Cool? Awesome. When you get in the back of the truck, we're now doing our treatment plan. So, are we transporting this patient? Probably yes. Polytrauma, you're gonna drive them. So that's why I kinda upped the treatment plan compared to our normal flow. Once you're sitting in the back of the truck, we should do some injury cataloging. So figuring out, okay, what are the injuries that I actually have? What am I worried about with these injuries? And what equipment or what do I need to do to make sure they don't get too bad? And then as you're kind of going through on the ambulance, you start transport, you can start working on vitals, you can start getting history, as you need to start initiating more treatment. So if you're thinking, oh, I might need fluid, let's get a blood pressure, let's see if we actually do need fluid. This guy might need some fentanyl, okay, let's get our vitals and let's ask him about his allergies, let's see what we cure sample. Does that make sense? So the assessments are gonna assessments and treatments are happening kind of as you need them, as they go. Beauty? Cool.
Just regarding cataloging this goes, since we'd be going through a head to toe, not necessarily like scribing
Yep.
everything down because we're getting quick about it. Would you be opposed to us being able to just have like a whiteboard marker or something and just copy paste since
Sure.
the bodies don't necessarily show?
Gotcha.
Oh, that leg is missing.
That's right. I'm not gonna make the CPSA SIMs too complicated that there's gonna be like 20 injuries. They'll have like 2 or 3. So it might be like a flail chest and a broken leg or something like that. Or an uncontrolled hemorrhage and I'm not gonna make them too wild that like, there's 7 stab wounds and they're all in these places. It'll be manageable. But if you wanna grab a marker and jot them down as you go, sure. Since you said it, let's talk about injury cataloging. I kinda threw this together. Anyone who's done the debriefs with me would have seen me kind of draw this out. So if you have hemorrhaging type injuries, so internal bleeds, external bleeds, we're worried about hypovolemic shock, we can be worried about pain, we can be worried about infection. So we'll control the bleeding, we'll bandage with sterile dressings, get IV access, 20 mils per kilogram fluid, throw some TXA at them. What's the dose of TXA? 1 gram, 100 mil bag, 10 minutes, absolutely. TXA comes in a 10 mil bag. So, a 10 mil bottle. So you got your 100 mil bag, you're gonna add 10 mils to it, of the TXA. So you're actually gonna have 110 mils in that bag. That's fine, as long as it's not like anything more than a 10% change, you really don't have to change the math. So you can just assume for math's sake that it's just a 100 mil bag. Does that make sense? Cool. If you put in 20 mils of fluid, well then you'll have to redo your math for a 120 mil bag. Because you're adding more than 20%. Does that track? Cool. There was, I think you had the question on that, right? Yeah. You could do it at math at 110 if you wanted, and it would be like a point something off. It just is not enough to make a difference. We're worried about infection. Sure, not very much. Certainly not in the back of the ambulance. So in terms of like prioritizing, I think hypovolemic shock's our first thing we're worried about. Pain control will be our second one, and then that infection that's gonna happen later, that's our third thing we're worried about. So for the pain, we'll give them some fentanyl, 50 to 100 mics, IV, IO, IM, whatever you've got. And then for the infection, we'll just do sterile dressings, clean the wound as appropriate. Cool? If we got some chest trauma, maybe it's a smack to the chest, maybe it's a stabbing in the chest, they could get a tension pneumo, they could have a flail chest, hemothorax, pericardial tamponade, short. I don't know why I put that there. We didn't really talk about much in lab, but it happened. So if it's a tension pneumo, we're gonna call ALS right away to get that needle decompression. We can also drive really fast to the hospital, quicker to get to the hospital, but call ALS. If they've got a flail chest, you're gonna support with CPAP or BVM/PEEP. You're probably never gonna use CPAP on these guys. So What's a flail chest? What's the definition?
It's two more broken ribs, broken side
So it's a section of rib broken off, right? It's not one rib broken, or at least sorry, it's two or more ribs broken in two or more places. So you get this like piece. People can have a flail chest and you won't see that paradoxical movement because their muscles hold the bone together. So I'm on a dirt bike and I'm doing some sick moves, some crazy moves, doing wheelies and all that fun stuff. And I take a jump and I fall off and I smack my ribs and crack my ribs. Nathan comes to pick me up, Nathan and Jonathan, and I'm fine. They give me a squeeze and they can feel my ribs move, but when I'm breathing, I got equal chest rise and fall, it moves evenly on both sides. I've got a flail chest, but I don't have the paradoxical movement. So if I don't have the paradoxical movement, we just give them a non-rebreather. We don't really need to do anything, because the muscles are holding that bone in place. Does that make sense? Yes, yes. Beauty. If my muscles start getting tired, as they're working hard, like little tiny muscles are trying to hold bones in place. So if I start getting tired, you'll see that that section of ribs is gonna start moving on its own, because the muscles can't hold it in place anymore. So if I'm awake, then we could use CPAP. And what CPAP does is it puts pressure, it basically splints from the inside, so that extra pressure in your chest helps hold the bones out. Does that make sense? So the reason you'll never give CPAP is the person has to be tired enough that their muscles are starting to get tired, but awake enough that they haven't lost consciousness. So there's that really fine line. It's like a niche question. I'm making fun of Charlotte for saying these like really odd scenario questions. Get me to think. So there's a really small window where you're going to see this, and you're not likely to see it. More likely what's going to happen is you'll have to get BVM with PEEP. So again, extra pressure, kind of making that BiPAP, they'll splint from the inside.
How does that fit in when you're in the back of the truck, if there's a partner driving and you're in the back and you wanna, put an IV and get vitals and stuff, but they also have
Yeah, you might not get those things, or you might have to do it before you go. So there's a risk-reward kind of calculation you gotta do to yourself. So let's say you two are working, I fell off my dirt bike and I'm messed up, and it's 45 minutes to the hospital. If my blood pressure's low, let's say I'm also bleeding somewhere, you guys need the IV, because I'm gonna be dead if you don't give me fluids before I get to the hospital, right? So, yeah, before Nathan drives, he's probably gonna have to get my vitals and get my IV. If my vitals are stable and we don't need the IV right away, you might say, you know what, start driving and I'll figure it out in the back. Does that make sense? Yeah, so you kinda have to like triage it yourself and decide. You guys are smart enough now that I'm not gonna give you like black and white answers for everything, because it depends. It's the famous medical answer, right? There will be situations where you will have to fool around on scene, because the patient's so sick, they're not gonna survive the 20-minute drive unless I have fluids going, unless I have their airway managed. So, and you need your partner for that. Does that make sense? And then there's other times like, you know what, no, frig it, I can do this by myself, just drive. And you roll into a merge, bagging a trauma patient who has no vitals and no IVs. Okay, whatever, it's fine. That make sense?
If you saw, like, if you were bagging and driving and you saw, like, signs that they needed fluids or something.
Partner, pull over, I need a hand. I need you to like, take over bagging so I can get an IV and some fluid in, because he's not gonna make it the rest of the way if we don't hurry. Or he goes into cardiac arrest while you're driving, you might like, no, get in the back, I need a hand, we gotta do something here. So yeah, we haven't talked much about that situation, but that could happen for sure. That'd be the same thing if you're driving, instead of a dirt bike accident, I'm having a heart attack, and then I go into cardiac arrest while we're driving. They can pull over, get back here, man, I need some help, we gotta get CPR on, we get pads going, we gotta get some things happening. Otherwise, we're just gonna be driving the corpse to the hospital. We don't wanna do that, we're not hearses, right? Awesome. Hemothorax, you're gonna manage it like hypovolemic shock. Pericardial tamponade, I don't know why I put it there. It's because I watched Chicago Fire last night, that first episode where she stabs him. Yeah, drive him to the hospital, they need to fix that. So that's a great example of like, if you did find a tamponade somehow, okay, nothing I can do to fix this, let's go, come on, drive. Cool. You're not gonna get a tamponade in your test. I'm not gonna give you a tamponade in CPSA. Absolutely not, it's silly. Head, face, C-spine injury, so kind of lumped all these together. They can get altered LOC, right? They good big smack to the head. You could have your airway compromised, so the gunshot to the face or the trauma to the face. You could have a spinal cord injury, like a C-spine injury. Or they could get some kind of neurogenic shock. So what are we gonna do? we're gonna keep the patient nice and calm, so if they're altered or confused, just keep them calm, try and keep them from hurting themselves, moving their head around, try and keep them nice and still. We might have to manage their airway with suction, airway adjuncts, BBM, eye gels. Maybe you're gonna call me as an ACP to intubate or do a surgical airway. Depends on what the airway's looking like. You're gonna maintain C-spine, so holding their head in place or a collar. And then that 20 mils per kilogram fluid bolus if they're in any kind of neurogenic shock. Probably gonna have to give more than 20 mils before it's all said and done. Most distributive shocks take like shit tons of fluid. Cool. And then if there's any fractures, we're worried about hypovolemic shock and pain. We'll treat the hypovolemia like we did any other hypovolemic shock. Fluids, IV access, TXA, 20 mil fluid, 20 mil per kilogram fluid. We'll splint any of the big fractures, the ones that are life-threatening, so broken pelvis, broken femurs, those are the ones we're worried about. Everything else, I just tie to the body, or like just support it as best you can, and save it for when you're in the trunk. We wouldn't be worried too much about that on scene. And then if they're in pain, 50 to 100 of fentanyls, perfect. Cool. Okay, thing goes back here. How are we feeling on our C-spine? Good. Okay. When do we hold C-spine? Yeah, right away. I'm having to lip read this, I'm not into it, guys. Yeah, so right away. Anytime you think there's a big enough mechanism that it warrants it, if you're unsure, just hold him. What if the patient has a deadly bleed? So I'm by myself and the patient has a deadly bleed and I'm holding C-spine. Let it go. Come on, Frozen, Elsa, start singing, let it go. Just go down to the bleed. I'm not singing for you guys now. Yeah, and here's our C-spine rule. I think it's important that we know this. You should be able to I don't care if you can verbalize every other dangerous mechanisms, but you should at this point be able to be like, yeah, okay, that's a dangerous one. Yeah, that's a bad, no, that's probably not. Maybe we're not too worried about that one. Does that make sense? Lovely. And it says radiography, because that's what the C-spine rule was written for. It was written for somebody to get an X-ray or CT of their head and neck. We're equating that to getting C-collar. So you won't find a C-spine rule that says, put a collar on. It'll just say radiography, but we're just equating those. If they don't need an X-ray of their neck, then we don't need to hold their neck in place. Make sense? And I'll walk through it because the no's and yeses sometimes confuse people. So if somebody has a high risk factor, they get a collar. If they don't have one of those low risk ones, that means there's something else going on. So if in my group in the lab, we talked about high risk factors. Just erase that something, and low risk factors. So if it's not, technically there's also medium risk factors, right? So if it's not a high risk one, and it's not a low risk one, then it must be a middle one. So we'll give them a collar. So if they don't have one of those high risk injuries, and they don't have one of the low ones, then it must be something kind of in the middle, so they probably need an X-ray or a CT. Does that make sense? Because when you look at with the yeses and nos, some people get really confused on this. So we're trying to find if they have a high risk one, or if they don't have a low risk. If they don't have a low risk, then they must have something in between a high risk and a low risk. So let's get a collar. If they do have one of these low risk ones, make sure they can look left and right. If they can, they don't need a collar, so they're fine. You've got your partner back, good to go. Cool?
So if they're unresponsive and the mechanism wants to.
Oh, absolutely, you can't rule it out, that's right. Too easy. Because you can't tell if they got the mechanism anyway. So, and you can't tell if they don't have paralysis or anything. Fluid administration. So when do we give fluids to people? Yeah, so when somebody's hypotensive, we're looking at shock. You can also give it for dehydration. You're not gonna get dehydration sims right now. I'm not gonna give you a dehydration sim. I just wanted to put it up there because the questions come up a couple times. What if they were just really dry? What do we do? So 150 to 300 mils an hour. For testing, this is probably what you're gonna get. If they're in a hypovolemic shock or a distributive shock, 20 mils per kilogram bolus. And again, we don't take the 2 liters and give them 2 liters all at once. We give them 250 mils at a time, we reassess. Lung sounds, heart rate, blood pressure. Yep, you still need fluid, here's your other 250. So that's a quarter of a bag. So every quarter of a bag we're checking. Cool? Somebody asked about pressure diffusers. That's just that white bag, you'll see them on the IV holes. There's a little white bag with a pump on it. You just slide that over your bag of saline and then you can pump it up and it just speeds up how fast it goes in. So if you're having maybe it's a shitty small vein or you're having a hard time getting lots of fluid in, or the patient's really hypovolemic and you want to get that fluid in faster, you can pump it up.
We don't need to worry about using that.
If you want to, you can, but I'm not gonna like hold you to it.
Okay.
Great. If you said you're putting like a 22 in like me as a big trauma patient, then I'd be kind of upset. Appropriate size IVs, right? Cardiogenic shock, we've kind of talked about that. Careful with your fluid admin, so 10 mils per kilogram, right? Again, reassessing as we go. So 250 mils, we reassess. 250, we reassess. Connie, you're really concerned, you okay?
No, I'm good.
Okay, you look really scared there for a second.
I'm okay.
What is fluid? Next semester, we're gonna start tying this to pediatrics. So that's why I keep saying mils per kilogram instead of saying like a liter or two. Because when you have like Sophia, who's 30 pounds or whatever she is, like that's only 600 mils. So little kids get different amounts. Cool? And we did this. Good luck. You guys are the best. Fine. Or you want, Tim Hortons will hire you. I checked before I left. We are looking for people in Stratford. Just if anyone wants.
McDonald's is paying.
I will pick up some applications for next week.
See that every morning.
There you go. Yeah, well, I won't go there anymore if I know you guys. Thank you. That's good.